Good evening, everyone, and good morning and good afternoon to all those who are joining us from the other side of the globe. Um, we are welcoming you to attend the Integrated Holistic Health C20 webinar under the Elderly Care and Palliative Care vertical on behalf of Mata Pradhanandamayi, our beloved Amma, and Amra group of institutions. It's my privilege to welcome you all on board. Have the introductory video.
This year, the C20 Integrated Holistic Health Working Group will comprise 7 subgroups with areas of focus that include mental health, nutrition, women's and children's health, elderly care, holistic health including traditional medicine like Ayurveda, as well as yoga and meditation, the reduction of non-communicable diseases, and One Health, a concept that highlights the interdependence of human, animal, and environmental health as one species, one world. Delving into these themes, we aim to widen the discussions on different facets of Sustainable Development Goal 3, good health and well-being, with policy building meetings and series of public webinars and awareness campaigns that will take place throughout 2023. These discussions will bring together health professionals, educators, and leaders from across the public health landscape to formulate policies that support global health and well-being. Inspired by the humanitarian activities of Amma, Shri Mata Amritanandamayi Devi, the present chair of C20, we hope that this upcoming series of events will raise the general awareness in society and spark interest in people to contribute to the conversation surrounding global health. As we embark on this journey to understand the health of the world around us, C20 will offer all members of civil society an opportunity to recognize how our individual experiences and efforts can lead to policy change. Let's work together to create a healthier, more equitable world. Good health is a fundamental human right, and it's up to all of us to make it a reality for everyone.
Thank you, Sudha. Let me also introduce, before we go on to introduce the speakers, the tech support. We have Sudha, Navneet, and Krishnapriya distantly supporting us, and we have Srijat right here for the webinar room support. So thank you so much at the outset. Now, this integrated holistic health webinar is designed to address 2 important areas of healthcare, which is artificial intelligence and the recent landmark judgment by the Supreme Court in the practice of end-of-life care in India. Artificial intelligence and related technologies are increasingly prevalent in business and society and are beginning to be applied more and more in healthcare. These technologies can potentially transform many aspects of patient care and administrative processes within providers, payers, and pharmaceutical organizations. In the coming decade, AI will be a major game changer in healthcare. This is without a doubt, we can all predict that. And to understand the nuances of AI in healthcare, we are joined by a world-renowned technocrat. Can we have Reema Poddar's bio slide, please? Thank you. So I don't know where to begin with, Reema, as you can see from her bio slide, has a master's in computer applications, master's in physics. Her slide is actually filled, and it will take, I think, probably half an hour to go through it and actually find the nuances of what she's capable of. But let me read the most important bits. President and CEO at Philips, DNP Informatics, Board of Director of Public Company, Board of Director of PE Portfolio, ex-Board of Advisor to Dean of UCSD, Top 50 Women in Technology awardee, Top 50 Business Women of California, Top 100 Asian American Hall of Fame inductee, recipient of several technology innovation awards. Above and all this, I can proudly say that she and I went to school together, and she was my classmate. And we used to hang out on the steps of her boarding house, and she used to be a boarder, and I used to be a day scholar. We used to chat generally about life, our families, etc. And still remember those days. And she basically had a passion for medical field, and she in fact qualified to become a doctor. But she couldn't join as she didn't have domiciliary at that point in time in Kerala. She is a Bengali by birth, but a Malayali by her upbringing, and she is an Indo-American. We are very proud to have you with us, Reema. Please, can we have a presentation?
Thank you, Shobha. So we are living the most extraordinary time in human history. It's unbelievable to see how fast things are changing. I'm sure you and I can relate to this from childhood to now. We have become more access to, the normalities of life is very different these days. You would agree with me that we have more access to world's information than any other time in human history. We have access to more computational power with more data at our fingertips every day. We are on the path of data getting democratized. And with the power of technological advancement, what we need to realize is that we are going to uplift the entire human race. Not in just the next 50, 40, 30 years. We are more looking at more like in a decade, and believe the power of things like what Shobha mentioned. One of the topic of discussion is going to be AI today, and we'll delve a little deeper in it. So ladies and gentlemen, boys and girls, if you're listening to it, I'm humbled and honored to share today's webinar from C20, as Dr. Shobha mentioned, and the Integrated Holistic Health, with my fellow esteemed panel members, Dr. Dhvani Mehta, Dr. Rajmani, and moderator and webinar hostess, Dr. Shobha Nair, who is a very good friend of mine. As she mentioned, we have a long history sharing our school days. So thank you, Shobha, for the kind introduction and for giving me the opportunity to share some insights into the role of AI as such and how it's transforming healthcare. Before I go into it, it would be a total mess if I don't self-introduce my dear friend, Dr. Shobha Nair. As many of you know, she is a highly esteemed physician with extensive experience in palliative care. Her expertise and commitment to excellence, commendable, unbelievable, because I'll give you an example as how she clearly is seen in everything she does, and be it as a medical professional, an educator, and something you all may not or may know is she's a phenomenal dancer. Yes, she's also a classical Bharatanatyam dancer. So I'm truly honored, Dr. Shobha, and I look forward to sharing meaningful dialogue with you today. You can't really pick any major magazine or newspaper today without seeing an article about big data, artificial intelligence, and machine learning. And there is a lot of fear associated with it. I'm sure you have been reading and keeping yourself up to date. I'm speaking to you all from San Diego, California today. And a few years back, I'm sure it was in the news in Americas, there was a lot of discussion around how our elections were going to be impacted. We talk about these days, will our livelihood be threatened by AI? How our economy might be under attack, and so on. In my humble opinion, it's not about the fear. It's about the possibilities. It's about the opportunities that is in front of us. And how we leverage AI along with us is the possibility. So before we start discussing anything about AI, let's just see how AI is delivering a valuable outcome for all. So please take a listen.
Alexa, play classical music.
Here's a station for classical music.
Well, my name is Jerry Neese. I'm 70 years old. And I live in an active adult community for people 55 and over here in San Jose, California. I actually have 5 desktops, 4 laptops, 2 Kindles, and an iPad. I have Amazon Alexa. I've had her for a couple of years now. And as someone that didn't even see my first television until I was 7 years old, I can tell you that the evolution of technology is inevitable. It benefits mankind. You can see the stars in the Milky Way. I can actually spend all day under here.
Artificial intelligence is all around us, and we use it in different ways every day. You wake up, you go for a run, and your watch tracks where you're going, measures your heart rate variability using forms of AI. Probably AI was used by a farmer to grow the crops and the strawberries and the blueberries that I had for breakfast. Maybe you're in a car that has AI that helps sense the other vehicles on the road around it. You sit down at your computer, you start to use your email. It's all filtered by AI. Maybe you take a photograph, and the tools that help you sort your photographs, those are AI too. Artificial intelligence is everywhere, and it's becoming ever more present in our lives.
What is the temperature in San Jose, California?
AI and machine learning is the biggest revolution today. And it's on the order of the agricultural industrial revolution in the past.
I think technology is going to have a really hard time helping people like me.
There's a lot of hype, but there's a lot happening as well.
Organic pasta.
One of the great things about machine learning is how it's been democratized.
A sort of huge jump has happened with, and all of a sudden you're getting confronted with the fact that I might not be driving a car in the next 10 years.
Because it's software, the rate of change is so much faster. This technology will be created. We have no escape from it now.
People may think AI is going to take over the world. They're definitely nervous. Some of those dystopian things that we might think, oh, that could never happen, might actually happen.
To me, it's not what's going to happen to us, but what's possible to happen with us. And where can we go? I mean, it's sort of unlimited.
So that is a powerful video showing you all facets of life and how AI is being used. So let's go and talk a little bit about, the technological advancement. One of the areas that has shown major success stories of our times is healthcare. No doubt about it. Medical science has improved rapidly, raising life expectancy around the world. But as the longevity increases, healthcare systems face growing demand for their services, rising cost and workforce that is struggling to meet the needs of its patients. This demand is driven by a combination of unstoppable forces, as you all would have seen and experienced during a pandemic. The population is aging, changing patient expectation, a shift in lifestyle choices, and the never-ending cycle of innovation being but a few. So look at the possibilities and how can we really start thinking about technological advancement and how do we really use them? So if you really look at this, the way things move is very different these days. Data is everywhere. It's part of our life, believe it or not. We may not realize it. The amount of digital data that exists that we create is growing exponentially. Think about WhatsApp. We are using every day text, video chat, calls, send images. These are all digital data. So data is the new oil and AI is the engine. If we compare data to the oil, then we can consider AI as the engine that converts its data into valuable insights and actions. Just as an engine converts oil into power to propel a vehicle, AI system use the data as fuel to drive intelligent decision-making and actions. So it's a very good analogy. The raw data is like crude oil, and many of us know that it has potential value, but it needs to be refined and processed to unlock its full potential. So what happens? Similarly, there are algorithms that is used in AI, and these has to be refined, these has to be processed, this has to be extracted for valuable insights from the raw data. And so that is artificial intelligence in some way or form, driving the positive outcome. But what you have to really think is AI will not exist without data. So think about the situation we are in. So much of data that's come across all over the place, and how we are going to really use the data. So many years back, everybody used to think I have to save this file, that file. And we used to keep saving all these files and think about the amount, the pile of files and the papers we used to stack up. These days, everything is digitized. So we have more access to data storage and everything. And with that comes complexities. Now, what do we do with all these historical data? If we are not really monetizing the data, how do you find the value? So that is where AI comes in. So what is AI? It's artificial intelligence. It's a technique which enables machines to simulate human intelligence. It's a broad field of computer science and engineering that really, creates and focuses intelligent machines that can perform tasks that typically require human intelligence, such as recognizing speech, making decisions, solving problems, and understanding natural language. So when you think about AI, there are many words that come into mind, and you see it in papers and magazines, as we discussed: artificial intelligence, machine learning, deep learning. So what I would say is, before we start really realizing what AI brings to table, let's just level set with the data and the definition at a high level. What does this mean? So if I'm somebody as a student, I'll think about AI as a superset of machine learning and deep learning. So AI is the grander word, the superset, as I mentioned, just mimicking aspects of human intelligence. It might be driving a car, as you saw in the video, translating a language. It might be recognizing a picture in a pile of albums and saying, this is the person's picture. One kind of AI is machine learning. So what does that mean? Where we are going to teach that computers to use those skills using the data. So it is also giving useful rules and boundaries. You have to, right? So if you really remember, when you start driving, you have to go and learn the rules of the roads. How do you really drive so that we avoid accidents? We save lives by not getting into a bad accident. So we have to have rules and regulations that we do. We learn the rules, we go take the test, we pass, and we then happily drive, and we memorize the rules, and we know we don't have to look it up. So it is it's the intelligence within us. Just like that, machine learning is fed the data, and it's given some rules and definitions and boundaries. So there are two types of machine learning. You will keep hearing them as supervised machine learning and unsupervised machine learning. So the supervised machine learning means we know the right answer. We know who is in this picture. The computer can get it right or wrong because we have already fed a numerous amount of pictures and said this particular person is Dr. Shobha, for example, let's say, right? So we can come up with a score, and how good is the computer able to identify the individual is how we do boundary conditions. When it comes to unsupervised, AI or machine learning, what it really means is that we don't know what's going on with this data. computer has so much of data. We have saved data in different places, different time, different historical and different structures. We have no clue how to really make sense of these data. And so then comes a technique that is applied called supervised, unsupervised learning, and deep learning plays a big role in it. It means use different kind of neuron that look like human brain. Try to mimic the human neural network. In other words, the human architecture to do this. So there are many kinds of these. These are devices. This could be software products that is used in some of our sensors. We have watches these days that really monitor your vital signs, your heartbeats, many of those things. So those are the aspects of in the AI. And so there's a different facet. I'm a strong believer, and sure all of you are, to appreciate the value delivered or realized of anything. It's always better to first understand the underlying problem. What are we trying to solve? Why is it such an innovative, outcome? So just like how we appreciate the internet these days, I can get data anywhere, anytime. I can call, voice over, internet, can connect with my friends and families. In emergency previous days, I remember when I came here, I used to spend $760 per month. I was not even earning so much at that point in time to just make 30 minutes call every week to my parents. So think now, I don't even have to pay a single pie. I can definitely call using my WhatsApp. I can video chat with them, talk to them. So let's spend a few minutes to know what the healthcare system looks like, because we want to appreciate what these technologies are bringing to bear. So what you see in the screen today is like, the three aspects. So you have providers, then you have payers, and you have other facilities or entities that really plays a pivotal role in our entire care pathway. So the healthcare providers are organizations and individuals like the clinicians, which we refer as the doctors, nurses, specialists, radiologists. They are healthcare professionals. Then you have the payers. So we have insurance these days, the organizations that provide healthcare services, they provide insurance. Then you have suppliers. I know I work for a company called Philips Healthcare. We are called the suppliers of healthcare because we provide and we build devices like MR and CT scanners. We provide software sits on it. So there are many different providers and healthcare suppliers like this. Then you have regulatory boards, and we definitely need that. The government agencies that oversee and regulate the healthcare industry, such as the Food and Drug Administrations. Then we have the governance that is built on protocols and things like it. On top of it, we have the researchers. So think about the ecosystem. It's all interconnected. It's interdependent with each of the components, playing a critical role in delivering high quality care for people like you and me. We are all patients and we are consumers to the healthcare system. So it's a very complex system, as you see. So let's bring us into the mix. Let's say we are the human being, we are the patient, that's it. What you're really seeing in the screen is a timeline of a patient. And if you see from left to right, and the little circles that you see there are healthcare consequences that happened, and underneath are different kind of data. I'm showing only 8 or 9 examples here. The diagnosis code, doctors and physicians, they can quickly relate to it and say, okay, when a patient comes in, they have a particular code that they have to say, yeah, this is, he has arrhythmia, or he has heart disease, or he's a diabetic person. So you might get that information. Then you go to the laboratory and you get test results. So you have data from that. You have medications, you have prescriptions, you have textual documents the physicians might write. Streaming data, the genomic data, imaging, CT and MR, I have to do X-ray. So think about the already complex ecosystem that we live in, and then what we as an individual, as a patient, bring on top of it. We have, when we are admitted in the hospital, we have bedside monitor that is monitoring your vital signs. You have all these data come in. So each square there you see is representing a piece of information. So there are like 4 or 5 associated with one event that is one visit to the doctor. And depending on where you get that information, it might slightly differ too. So there is variability that gets introduced. It's a bigger problem, right? So AI really comes into play here to really bring operational efficiency, to streamline this process. This is where AI helps tremendously in the healthcare. So let's just make sure we take a listen.
The advent of AI in healthcare.
In this age of technology, artificial intelligence knows no bounds. Once thought a futuristic threat to humankind, AI is changing and saving lives. Not intended to replace clinicians or clinical judgment, AI serves the purpose to enhance and complement the very human interaction of provider and patient. In healthcare, AI is changing the game with its applications in decision support, image analysis, and patient triage. With their ability to reduce variation and duplicate testing, decision support systems quickly decipher large amounts of data within the electronic medical record. AI technology is also taking the uncertainty out of viewing patient scans by highlighting problem areas on images, aiding in the screening and diagnosis process. Artificial intelligence helps with the issue of physician burnout by collecting patient data via an app or text messaging. Chatbots now ask patients a series of questions regarding their symptoms, taking the guesswork out of self-diagnosis and saving both the patient and provider time and money. With the AI integration, working smarter enables solutions to a variety of issues for patients, hospitals, and the healthcare industry.
So to make sure we don't let AI go rogue, we need to put some governing principles in place. And we call that responsible and trustworthy AI framework. The framework that is in front of you really accounts for fairness, safety, security, reliability, just like what we do in medical and pharmaceutical industry. It needs to take into account data privacy, your personal information, your personal data. How do you anonymize that? Needs to be taking care of unbiased approach. That means, you might collect all these data, maybe from a particular demographic, but you cannot just use that same data to a different demographic because our lifestyle is different. The food we take is different. The biochemical changes, the environment, all of them are different. So we have to really make sure that we are really taking into account all aspects of it when we really start building a fair AI solution. Very important. And in fact, I would say
the advent of AI in healthcare.
So if you go back into the different way of doing things right now, if you also look at medical side of things, you go to CT and take CT or MR scanners, and there are images that comes into play, right? So what do? You also see radiologists really writing reports, AI reports. And so there are governance principles called MINIMAR. I'm not sure many of you have heard this. It's called the minimum information for medical AI reporting. So there are principles, rules, governance that's all put into place. So the next one is a video I really want to show because this is something that is widely known to all of us. Many of us suffer to this. And at times it's difficult to diagnose. So sometimes it's misdiagnosed and how AI is helping in it. Take a listen.
The advent of AI in healthcare.
Sorry.
Breast cancer is most commonly found on a mammogram. Mammograms, unfortunately, like most diagnostic tests, are not perfect and can't always catch the cancer. In fact, up to 1 in 5 women can have their cancer missed on a mammogram. There are 2 main challenges with diagnosing breast cancer with a mammogram. The first is a false negative, or missing a cancer. There's the other side of the equation, which is the false positive, which means we think they have cancer when they don't actually have cancer.
Computers learn a lot like humans. They learn by example. And in order to teach a
computer how to interpret mammograms, we had to show it many, many examples, those that contain cancer and those that don't. And we supervise it and we say, these are the cases that are positive and these are the cases that are negative. And after many, many iterations and showing them and through trial and error, it will eventually learn to get things right. So we had 6 radiologists look at all these cases and decide whether they thought cancer was present or not. We had the algorithm do the same task, but it did much better.
The most exciting part of this work is that we're able to catch 9% more cancer at screening. Also very exciting is that we're able to reduce the amount of false positives by 5 points.
So reduce the false positive by 5.7%, or in other words, 6%. It's super, unimaginable if in case you think about it, think about the amount of, patients would be there and how quickly and fastly you can triage this data and diagnose it better. So Tim Cook, the CEO of Apple said, and I quote, "What all of us have to do is to make sure we're using AI in a way that is for the benefit of humanity, not to the detriment of humanity." So something that will be very interesting for you, and I'm not sure if any of you have watched this. I have personally watched this, and this is called Matrix, a movie that came in 1999. And what Matrix is, really is telling as a cautionary tale about the potential dangers of AI and warning against becoming too reliant on machines. It emphasizes the importance of maintaining control over technology and ensuring it serves humanity's best interests. So if you haven't watched it, please do so. And I'm sure there are a couple of series that came in also after that. I have personally watched them, and it's fantastic to really realize and say, control it, what we need to be done, and how you really leverage technology. So I'm personally very enthusiastic, optimistic about our future with the right framework, ethics and governance, and technology like AI can deliver and will deliver a brighter future, not only for us, but for the future generation to come. Thank you.
So thank you for that excellent, comprehensive presentation, Reema. You kind of covered the questions that I wanted to ask. But before I ask anything, can I ask the audience if they want to ask? Not sure whether you can unmute or you put it in the chat. So that is it possible for them to unmute and talk?
Yes, if anybody would like to raise their hand, we can allow you to unmute and ask your question.
Yeah, we have somebody who had raised his hand, Kanaga Sabai. Would you like to ask anything, anyone?
One moment.
Yeah, I can see Manorama's hand raised.
You can unmute now.
Can I?
Yes.
Someone is saying right now. Someone is already asking question, or I can?
No, you can go ahead, Manorama.
Okay, thank you so much. Thank you so much, first of all, Reema, for this wonderful presentation. Actually, I have come across, since I work in healthcare domain, I have come across like some of the people like who are actually now sort of like microscopy, the manual microscopy, which normally, used to be there in all the labs and all that. Now, due to AI, there is something which is coming up that they don't want to be either a radiologist or somebody who can write the reports. Rather, they want to put all the slides and they want to reach the last, what we call the reaching the last mile, so that from sub-centers, PSCs, CSCs, and, district hospitals, all data, all slides can come at somewhere in the state or anywhere in remote place, wherein the AI can give the reports and the reports can be churned out much faster and within a fraction of a second. But then the question is that still it is not being taken up very, positively, because government is also, looking and watching. It is wait and watch, and I don't know how much time it will take. But then there are startups who want to take it off very quickly. wherein like in ministry also there are so many things which have come up, like Disha platform has come up, which is something to do with digital, ethics and digital approvals from the ministry side. So some of the startups are getting frustrated because a lot of people have come now in this domain who want actually, so how we can sort of like from C20 give that kind of inputs, policy input, which can go into that the way you said that Tim Cook from Apple has said that everyone needs to use it, something of that sort of policy directive wherein people, I mean governments can also take it off. Maybe like we can have hub and spoke model in the beginning. For a couple of them we can have like the one person looking into maybe 30-40 centers, but let the AI do the work. That kind of a thing if we can initiate or something, and if it can come from this platform. Thank you, Reema.
Yeah, no, I think Shobha, you may want to add some of those things also, but I can tell you a fantastic analogy. And personally, I would say is the hub and spoke model that you discussed is already prevalent here in, especially, I'm very proud to say that recently my organization, my business, in fact, my team delivered a product and this is exactly for the use case you were talking about. And we have deployed it in a very big organization called RadNet for how AI can really play with data and intelligence, looking at triaging data, looking at radiology imaging, generating reports. Not just that, it also is allowing people to do over-the-shoulder training. So think about, I did mention in my presentation that there is a lot of burnout, and believe it or not, we don't have enough healthcare professionals who can really meet the needs of the demands that's generating every day. So we need to leverage some technology. And so the mature or the professionals who are highly experienced, 20 years, and the out of school grads, they need to be an over the shoulder training that needs to be done. And so what radiologists do is, a seasoned radiologist in America might be training somebody in Spain and India, and train in the sense as the person really got out of school, understands it, but needs clarification, right? Anytime, anywhere, and they can collaborate and do it. So the amount of the outcome that we can realize through all this technology is huge. And how we can, to your point, is how we can really bring to bear to countries is by showing these testimonies, showing these results, showing these getting leveraged and producing outcome, along with some governance, sharing of information from different regions, countries, and others. So, if you want to really add something to it, Shobha, please go ahead.
Reema, I think you had promised us that if there was a platform where you could help us, I was talking about Amrita, that you're willing to kind of pitch in. So like Manorama said, she works with government policies, and she's a major influencer, and she literally goes to the rural parts of India. If there's no transport, she will go walking to those places, and she's walked miles and miles and miles. She's not yet slept. So she comes from that place, and she wants to actually, make it happen. So I think we can, get back on that.
I'll be there.
Yeah,
I can absolutely do that.
As Manorama said, this is a C20 platform where we can actually form a group and we can take it forward, because it's probably we'll not be able to answer it completely here. I think I see a couple of hands raised, and I think we'll take two more questions. One is Dr. Pereira. Dr. Pereira? Can you unmute yourself?
Okay, it's unmuted.
Yeah,
I must say that this is very fascinating, but for people like me to really understand how to connect this artificial intelligence into a domain of elderly, that we are looking at it, that link I'm finding it very tough. I know that I need something to support the elderly across because there are a lot of variables in elderly, like they're from the rural background, they may be illiterate. I'm talking about the Indian scenario, or they may have a different disease spectrums. So when you're talking about it, we need artificial intelligence to make them as much as possible independent as possible. We may need artificial intelligence to help the carers or the family people. We may need artificial intelligence, to for their inherent safety, or connect to the tertiary. So I'm kind of wanting to know, how is it that we this link I would like to understand as far as elderly. But there is a dearth, there is need. But when I sit down to it, my mind gets thrown off to all the areas. So how would you help in the field of elderly?
Yeah, you actually gave the answer within your question itself. Honestly.
Oh, okay.
Yeah. But just think about it. You said, there is a lot of care professional that goes into meeting the needs of that, whether it's rural area or not. You wouldn't believe the title of my slide today, from cavemen to cyborgs. Believe who gave me, who gave me that title? I just used ChatGPT. ChatGPT is a different form of AI right now. It's everybody's hearing about it. I used ChatGPT. I went and said, hey, listen, I'm going to present to an audience, and I'm going to really talk about how technology, specifically AI, can be used, and what are some of the outcomes of it. So give me a great title about it. And it came up and gave me from caveman to cyborg. And then I went ahead and asked, okay, what do you mean by cyborg? That was the first time I'm hearing. So it just basically said, hey, that's human and intelligence. And this word was not formed today. It was formed in 1960. So I'm just giving you a context, because just coming back to the rural scene, about the opportunity that is there right now. Everybody in India has some form or shape of mobile access, right? Not maybe at least 90, in rural areas. Where you can really envision this is going is ChatGPT could be leveraged for asking questions. Saying, oh, I have somebody, my mom is going through, and they might be, and then saying, what can I do? What are something? So the chat really starts asking voice recognition and translates in the language. Okay, so it interprets your language. Could be Tamil, it could be Telugu, it could be Malayalam, Hindi. It could do that recognition, translate, and provide the data to think about the plethora of opportunity around us. And you gave the answer within your question itself. Bravo.
Right. Thank you, Reema. And thank you, ma'am, for that question, because I know you're very passionate about elderly care, and that's where you're right now. And she's heading the JSS Mysore geriatric department. In fact, last week, Reema, we had the working group summit at Faridabad, our own hospital there. And during which we had one session on digital health, in which the translational AI was talked about. And then I was going to ask you about ChatGPT anyway, so that's been answered. And we'll go with the next person who talked. Is it Rajneesh Kumar Sinha? Would you like to ask, sir? Yes, please go ahead.
Yeah, good evening. This is Rajneesh Kumar Sinha, Project Director of Dhvani Mehta Foundation Trust.
Can you speak a little louder, sir? Keep the mic closer to your face. Keep it.
Okay.
Yeah.
Okay. This is Rajneesh Kumar, Project Director from Dhvani Mehta Foundation Trust. Am I audible?
Yes, sir. Keep your question. Yes, sir. Keep your question to the point, sir. Thank you.
Yes. I am going to the point. I just like to know, what is the limitation of AI in medical sciences?
Oh, what are the limitations? That's the questions of AI in medical science. Absolutely, there is a lot of limitations also, right? And it depends on how you need to really think about. I think in the presentation, I did talk about how AI is fed data. There's supervisory, unsupervisory, regulatory rules, and it has to be defined. So what we'll have to really look at is not letting AI go ahead of us. And just think about it. I don't think so. Look at ChatGPT for an example. If you go back and start using ChatGPT, it'll tell you, listen, the data that has been fed to me till now is till September 2021. I don't have data after that. So you need to really, so there are limitations in when it comes to medical field is all about, this is how I take it. You can get best out of AI, but finally human needs to be there to make the final call of it. So, at the end, we all know who gave birth to AI. It's us. So basically there are a lot of limitations to AI if it's unsupervised AI and you're just taking the data that unsupervised AI is giving you and blindly using it. So that's how I would leave it. So there are a lot of pros and cons, and you have to still do it. Will we make advancement? Absolutely, but it has to be within a bounds and boundary conditions.
Yeah. Thank you for that, Reema. And I was, just going to say, AI can't have emotions like human beings. So our presence is required. And it reminds me of several incidences in the past where when computers came in to a particular state, people took up strike and said, we don't want computers because it's going to take away job opportunities. It's something like that here. We healthcare professionals are a little worried that we'll lose our jobs. But I suppose that's not the case. In fact, we need to make it work. So we should be there to make it work is what I understand. And, if there are no pressing questions at the moment, I think we'll go on with the next presentation. We are past 5 minutes from this presentation, and we've just overshot 5 minutes, which is fair enough. It is a very comprehensive topic, and you have kind of put it in a nutshell so very well, Reema. Thank you so much. Please stay till the end. If we have time, we might take more questions. Can we move on to the next half? The second half is all about end-of-life care decisions. And as healthcare professionals and just general population, what do we do to make end-of-life care decisions smooth and functioning? A constitutional bench of the Supreme Court, headed by Justice K.M. Joseph, passed a verdict to make suitable amendments to the previous procedure regarding making an advance medical directive or a living will and withholding and withdrawing life support treatment in the month of February in 2023. And this landmark judgment is set to be the game changer in the practice of end-of-life care in India. And to dispel the ambiguities surrounding withholding and withdrawing life support, we have two eminent speakers. They're not only eminent speakers, they have worked tirelessly, relentlessly to make this happen over the years. And they are Dr. Dhvani Mehta and Dr. Raj K. Mani. Can we have Dr. Dhvani's bio slide up, please? So as you can see, Dr. Dhvani Mehta is a lawyer. She's a co-founder and lead health from Vidhi Center for Legal Policy. She's a co-founder of the Vidhi Center for Legal Policy, an independent think tank that does legal research to make better laws and improve governance for the public good. She leads Vidhi's work on health law and policy and has been working on the legal and ethical issues surrounding end-of-life care since 2015. She has appeared in the Supreme Court of India in the case of Common Cause versus Union of India, which recognized the legal validity of advanced medical directives. She has also appeared in the Supreme Court on behalf of the Indian Society of Critical Care Medicine to modify the court's guidelines on withholding and withdrawing medical treatment. In collaboration with the End-of-Life Care in India Task Force, ELICIT, she has spearheaded Vidhi's drafting of a model bill on end-of-life care. Vidhi, we're so fortunate to have you speaking to us today. So please go ahead. She doesn't have a presentation. She's just going to speak to us. Thank you so much.
Oh, thank you. I was actually wondering whether it would be more useful to have Dr. Mani speak first. He's the more experienced person as part of this collaboration, and it might make sense for me to have my inputs come in a bit later. So I would suggest if Dr. Mani doesn't have a problem, I would like it very much for him to begin the talk.
I think that's fine by me. I think that would be more appropriate because Dhvani can summarize and sort of
exactly.
sum up the situation, legal situation.
Sure, sir. So if she was probably going to talk about legal frameworks, and sir was going to talk about the practical implications. So can we have Dr. Mani's bio slide first, please, and then his presentation? Thank you.
Stop sharing.
1 second, sir. Let me read out your bio. Just give me the privilege to do it. So Dr. Raj K. Mani, Director, Clinical Services, Pulmonology and Critical Care at Yashoda Hospital, Kaushambi, Ghaziabad. And he has contributions in non-invasive and invasive mechanical ventilation and extracorporeal lung assistance. And he has been the president of ISCCM, which is Indian Society of Critical Care Medicine, and chief editor of the IJCCM, Indian Journal of Critical Care Medicine. Dr. Mani has been involved in the intersecting regions of medicine, ethics, humanity, and law. He published as a lead author in the seminal guidelines by the ISCCM for end-of-life care. As a member of the End-of-Life Care in India Task Force, ELICIT, of which Dr. Dhvani is also a part, initiatives to improve EOLC was taken up and went up to the legal policy. And he had pleaded in the landmark judgment, Common Cause versus the Union of India in 2018, that established the I can't see because there's some pictures over there. So execute a living will and to refuse life support. He was a task force member with ICMR for 2 papers, with landmark papers on definition of terms used in EOLC and guidelines for death and dying. And representing the ISCCM, he was appellant in the recent Supreme Court judgment for simplifying the procedure for withdrawal and withholding of life support in terminal illness. This is so important, sir, because for people like us who are in the hospital ethics committee, deciding on whether to withdraw, the ventilatory support, and all the others who work day in, day out in hospital, and also the relatives and the patients themselves, to know about this. So please go ahead, sir. Please, can you share your screen?
It was a treat to listen to the AI presentation and what the future might hold for us. See, AI, what does it do? It takes care of the huge logistics involved in healthcare, at every level, right? Be it diagnostics or the organization of healthcare, or be it research, and so on. I mean, there are so many other implications. It will perhaps reduce the uncertainty surrounding intensive care, but it can't obliterate it, obviously. We are going to talk about the opposite end of the spectrum. See, medicine is evolving rapidly on this side. It's also evolving rapidly on human centricity, if you understand what I mean. So on the one hand, AI is taking the human side out, so to speak. I mean, to a great extent, it is outsourcing it. But then it's all for the human being. You can't take the human out of the human being and the natural intelligence out of the artificial intelligence. And all this comes to a head, this personalization, right? Every individual is unique, and our treatment of that individual is likewise very personalized. All that comes to a head in terminal illness because in all the history of mankind, we have not been able to conquer death. So we're going to get there, and then there is no holistic medicine, holistic healthcare, without caring for the dying. It's happening in our midst every day. And first and foremost, in all this romance of technology, we mustn't forget that death isn't alien, right? Life and death are one cycle. So these are the words of Thich Nhat Hanh. A cloud never dies. Wonderful, isn't it? So it's the cycle. It's a sustainable, natural, sustainable cycle. Cloud turns to rain and water turns to vapor and cloud again. So it's a zero-sum game, right? And if we realize this, and we wouldn't be, in spite of all this romance of technology, be a death-defying and death-denying society. And as a physician, I won't call it a defeat in the face of a dying patient. I would think it as an opportunity to help and care uniquely, care compassionately. And that's what it's all about. Recently, we had the Queen die in her own home in Balmoral. And Catherine Mannix, a famous palliative care opinion leader and author, tweeted this. I immediately picked up this picture. The Queen has just shown the world the process of ordinary dying. It's become so precious, this ordinary dying. All right. What we have done is actually ruined the poetry and the spirituality associated with dying, which we always been there. We have associated it with technological fuss. Okay. And a lot of the advanced societies, which are very advanced in healthcare, have stumbled upon this idea that we should reduce this technological fuss towards the end. You can see the evidence. See, Barbara and George Bush chose to die in their homes. But this couldn't happen for people who we regard as extremely precious and valuable in our midst. We couldn't give them the choice of a peaceful end, dignified end, because we have not discussed this issue. We have ignored, for reasons out of fear or extraordinary expectation of advances in medicine, or just the fear of the unknown. We have not discussed the issues around death and dying, which intersect with so many things in the society. Okay, it's not just about healthcare and medicine. It's about the culture. It's about our policies, law, economics, environment, what have you. You can see that we in India come very low on the list of dignity in death scores, right? In the quality of dying indices. And one of the most important quality, indicators of the quality is not being unnecessarily prolonged in the dying process. It's a criteria for good death by a huge meta-analysis of meta-analysis, right? And you can see, because this excessive treatment, this urge to do something always, and never to stay the hand, affects everybody involved in the process. Of course, the patient gets unethical treatment. Ethics behooves us to always have the weight of benefit more than the harm, right? And the harm isn't just to the body or the physicality or the physiology. Harm is to the personhood. Harm is to the value system. Okay, and so on and so forth. So we're going against the basic ethical principles if we are not weighing and considering and being reflective in what we should be or not be using towards the end of life. To the family, of course, huge dissatisfaction, emotional burdens, anxieties, post-traumatic stress disorder, huge economic, catastrophic economic burdens. And to the caregiver, you see, we as caregivers are not exempt. We are not mute witnesses. What's happening around us, we are affected. Causes moral distress, compassion fatigue, and depersonalization, the urge to leave work, go somewhere else, right? And then violence at work. Dhvani has written about it. She has researched on this, and it is real. It's in our midst, and it's a big threat. And then the healthcare systems. We have witnessed it, what happens in the COVID pandemic. When there's scarcity, and then there is accentuation of inequities, and there's resource misutilization. But you see, there's been an intersection of law and end-of-life care. And in the high-income countries, it is relatively better developed. And in many of the middle-income countries, not well developed in the low income and countries of most of Asia. For reasons of death being a taboo subject, or culturally we have created barriers to not discuss it. It happens to us personally as well. We don't want our father to know what is going on, and we request the doctor not to reveal everything, right? And to protect psychologically, believing that this sort of making it a taboo subject is somehow going to get us to deal with it better. But no, it gets us to deal with it far worse. 70 to 90% of deaths by large studies in the US and Europe have revealed are being allowed to go through a withdrawal and withholding or a DNAR process. Or this choice is given, and most of them are seizing this chance. And then in our setting, formal foregoing of life support decisions have been very few and far between. You can see it in this meta-analysis of about 56 countries. Our representation is very small, and our frequency and the prevalence is also very low. And in particular, the withdrawal decisions which are in the black bars, they are much, much lower as compared to the rest of the world. Now, most of these withdrawal decisions, even if they are withdrawal withholding decisions, they are passed through this strange process called a LAMA, left against medical advice, which has no basis in the goals of medicine or in ethics or even in law. And that's a different subject, but this is what we are forced to do. Randall Curtis is one of the pioneers of humanizing intensive care, that is introducing palliative care in intensive care right since the early 1990s. We lost this pioneer recently this year in February. And this was one of his most recent editorials, wherein he has created this picture that there is an ecosystem of law, policy, culture, institutional policy, individual physician and patient beliefs and attitudes. All this impact on end-of-life decisions. And this structure, you can see it unfold in our situation, our AOL situation, our country. So for a long time, it was very difficult to nudge the law to enable these decisions for us properly. Starting in 2006, the 196 Law Commission report on the medical treatment of terminally ill patients for the benefit of patients as well as physicians. That's what it said. And starting from there, we had a very slow progress. However, we got there with this landmark paper, judgment called Common Cause versus the Union of India, in which the ISCCM pleaded, and we established without any ambiguity the validity of advanced medical directive and a legally appointed proxy. And in combining the privacy judgment of 2017 and in establishing autonomy as a part of the Article 21 right to life, there is a right to choose the manner of your treatment towards the end. There's a right to refuse unwanted treatment. All this is constitutionally now well established, and thank God, thank the lordships for that. However, we lost our way in the procedural guidelines prescribed by the court, which was a three-tier system and was unworkable from the moment we set our eyes on it. In the meanwhile, we also had path-breaking statutory guidelines from the ICMR, which is the premier medical ethics and research regulator in the country and advisor. So DNAR is the simplest and the earliest in the spectrum of withholding life support. That is, you refrain from doing CPR where it is not indicated, because CPR is also a medical intervention. And it is undignified to undergo CPR when you're only dying and it's expectedly happening. Then we have, by the efforts of Dhvani's Vidhi Center for Legal Policy and our senior advocate, Arvind Datar, the ISCCM, together with the support from the illicit, we could first appeal for a simplification of this process, and then finally drive a consensus between the Ministry of Health and Family Welfare and the ISCCM and other stakeholders. We could drive a consensus so that we can have a workable legal process. So we got this to a great thrill and hopes. Next day we got this information that SC simplifies its order on so-called passive euthanasia. I have a grouse with this term, but what they really meant was withdrawal and withholding or foregoing of life support decisions towards the end of life in medicine. So I won't go into this process because that's what the Dhvani is here for, and that's what it is. It is her baby. And, although, well, I kept interfering in the process of making these legal guidelines, in the end, it was something we could use by the bedside, something which gives us hope, something we believe is groundbreaking to humanize medicine, to not only allow artificial intelligence to grow, but grow only with the dimension of more and more humanizing. And because all this effort is for the human being, and there is no greater service than to ensure when the end comes that it is peaceful and dignified. Thank you very much for your patient hearing.
So thank you, sir. I think we'll all listen to Dhvani and then go on to take the questions, if that's okay. Yeah.
Sure. That works very well. And it's always a pleasure for me to give a talk like this in partnership with Dr. Mani. I consider him a steadfast partner now on this journey, and I'm really privileged to have worked with him. And even though we've given so many of these talks, I have something new to learn from him every time he speaks at a forum like this. So I'm just so grateful for this. And I'm so grateful to you, Dr. Nair, as well, for this opportunity to allow us to speak to another group of persons who are interested in and passionate about this issue. So I think Dr. Mani has laid the ground beautifully and set the context very well for what I have to say. I'm just going to very briefly explain what the actual legal procedure is at the moment as regards withholding and withdrawing life support treatment. And I would also like to add what are some of the important legal principles that the court laid down. I mean, Dr. Mani has already touched upon them a little bit, but I think it's important for us as doctors, patients, family members, caregivers, to not just understand what the procedure is and what we're supposed to do, but to also understand what are the core legal, ethical, humanitarian concepts at the heart of this important issue. So I think, again, we've always been telling people not to see this only as a legal issue and to not let your practice on this be guided only by the law. Do the right and ethical thing, and the law will follow to support you. So I'll begin by laying down what some of the overarching principles are. I think the most important principle is that the court recognizes the right to autonomy as an integral part of the right to privacy and dignity and liberty. So it understands that the right to refuse medical treatment, even if it results in death, is an important part of your ability to exercise your own and to make your own decisions as an individual about your own body and the way in which you would like to lead and end your life. So I think this is the most important principle at the heart of it all. There are other important principles that are at stake for doctors themselves. So for example, the court also recognizes that doctors are under no compulsion to provide medical treatment that they don't think is in their patient's best interests. So, no one has the right to go in and demand that every kind of life-saving measure be applied at all costs. I mean, it's another matter that in a day of, in an age of privatization and sort of commercialization of healthcare, this may be the norm. But for the ethical physicians out there who know when to stop, they must also know that the law recognizes and supports this, and that you must only act in your patient's best interests. You don't have to, put every patient that you have on an ECMO machine because that's the right thing to do. If it's not the right thing to do in medical terms, then it's also not the right thing to do as far as the law is concerned. The other things that are less clearly laid down in the law, but that are also important for us to keep in mind as a society, is that there are different kinds of standards that are used while taking medical decisions on someone else's behalf when they themselves have lost that capacity. So the reason why this judgment is important is precisely because of this reason. It's allowing you to take a decision for yourself by executing an advanced medical directive or a medical or a living will, as it's more colloquially known, so that it will apply at a time when you no longer have that kind of decision-making capacity. So it recognizes that you can make this kind of decision for you in advance. And the other thing is that it also, if you haven't made a directive like this, it doesn't mean that you are you're compelled to, you're resigned to a fate of being hooked up to a ventilator in an ICU. No, even in such instances, and we understand that these are going to be the majority of instances in an Indian setting, at least in the initial years until people learn more about making an advanced medical directive. We know that most people are going to be in a situation where they have lost decision-making capacity, but have not made an advanced medical directive of any kind. So the court's guidelines that Dr. Mani mentioned that were laid down in February 2023 are also intended to apply to people like this. So this is, I think these two are two very remarkable legal developments. And while these have been recognized, it also brings into play the question of, how are you going to make this kind of decision on someone else's behalf? Because even with the advanced medical directive, you are required to appoint a surrogate decision maker or a healthcare proxy who will be making these kinds of decisions with your treating team. So there is going to be an element of someone else coming in and thinking about how these decisions can be made. Now, in the literature, there are two distinct schools of thought, really, though perhaps they're not as different as they should be. One is the best interest standard, and the other is the substituted judgment standard. So in the first standard, you take a more well-rounded decision. In the sense that you take a whole host of factors into consideration in determining what would be in the best interests of that patient. And in some sense, that's therefore perhaps, I don't want to say which one is more objective or subjective, but let's say that here, this is a standard that you will apply taking into account medical, personal, and any, other factors that may be involved in deciding what is best for this particular person. Whereas in the substituted judgment standard, you would take a decision as if you were that person yourself. So this is the standard that's been more in vogue in American courts, whereas in British courts, as well as in the Mental Capacity Act in the UK, it's the best interest standard that's preferred, while recognizing that a person's own personal preferences are a part of that best interest standard. So personally, again, as a lawyer and as a policymaker, I think that standard works well. And while our court hasn't really applied its mind as much to that issue, or hasn't gone into that in as much depth, I would say from a general reading of the judgment that that's the kind of standard that is expected to be applied. So these are some of the broad these are some of the broad legal principles. These are some of the more complex legal and ethical issues that a judgment like this raises. So now I will get down to the brass tacks and speak specifically about what were the original 2018 guidelines on withholding and withdrawing life support treatment, and what are some of the key changes that have been brought in through this particular through these most recent guidelines. So in 2018, the difficulty was that advanced medical directives could be executed only before a judicial magistrate of the first class. Now, these were very difficult to access. They themselves didn't know for the most part what their duty was. And there were very few people who managed to get their advanced medical directive executed. Now, that has been modified in these recent guidelines so that living wills can now be executed before a notary or any gazetted officer. And most of us have got some document or the other notarized in our lives. So it's to be hoped that this will be an easier experience. The other process then, the other changes in the guidelines refer to the 3-tier process that Dr. Mani was talking about, and he had actually laid out a wonderful flow chart that describes this in perfect detail. But I'll take you through what the key changes are. So in the initial judgment, the first step involved constituting a hospital medical board, which had the head of the treating department and 3 other experts from particular named specialties with more than 20 years experience, who would decide whether a particular patient was a worthy candidate for foregoing life support. Now, this has been changed in the more recent guidelines, so that the hospital can set up a medical board with just the treating physician and 2 other subject experts with at least 5 years experience. So again, that makes it much simpler. In all probability, of course, it will allow this hospital board to be constituted in-house. It doesn't specify which specialty these physicians must be from. And, in general, this is obviously a much less onerous requirement, at least as far as getting members together for this kind of board is concerned. In the next step in the 2018 guidelines required the decision to be confirmed by a second medical board. That was to be constituted by a collector and to comprise the district chief medical officer and 3 other experts with similar years of experience, so 20 years experience. Now, again, this was actually an even bigger stumbling block, because this involved government functionaries who are already overburdened and would not have the capacity to create and nominate a board like this every time a decision on foregoing life support has to be taken. So this has again been modified in the most recent judgment to a secondary board that again will be constituted by the hospital. So very much in the hands of the treating hospital now, and to comprise a doctor nominated by the chief medical officer and 2 subject experts. The only requirement being that these subject experts are not part of the original primary board and also have at least 5 years experience. So again, this makes things much simpler. It brings, as Dr. Mani said, brings this all within the realm of possibility. And after this, the court has said that the treating team and the physicians discuss this with either the person named in the advance directive as a surrogate decision maker, or with the next of kin or next friend or guardian if there is no advance medical directive, get them on board as far as withholding or withdrawing life-sustaining treatment is concerned. And once that consent is obtained, you can this decision to withhold or withdraw life support treatment will have to be intimated to the whoever is the relevant judicial magistrate. So You just have to inform the judicial magistrate that this process has been followed and this decision is being taken. You do not have to wait for their prior approval. Under the earlier judgment, the judicial magistrate was required to visit the hospital before any decisions on withholding or withdrawal could be implemented, which I suppose was actually the most unworkable most unworkable aspect of these guidelines. So this is the way in which it's changed. I know there are still lots of unanswered questions. We've already done sessions with other doctors and other groups, and some very valid, pertinent questions have come up about what doctors feel they can and they can't do. Again, my advice to everyone is that this is now the time to do your best to implement these guidelines in good faith as the medical community, as the caregiver community. There is a lot of clarity from the court. There is, the procedure is one that is that can be implemented and worked out. Where there are doubts along the way, do whatever is the right or the ethical thing to do. All hospitals, of course, have legal teams that will advise them. But don't let I don't think this is the time now to let the fear of the law prevent you from implementing end-of-life care decisions and providing the right kind of palliative care and support. As Dr. Mani said, to continue to implement withholding or withdrawal by a leave against medical advice or a discharge against medical advice kind of decision will be to defeat the purpose and spirit of this judgment. So happy to take any questions that there might be about actually implementing this procedure and anything else that anyone might want to ask. Thank you.
Thank you so much, Dhvani and Dr. Mani, for covering the legal aspects of end-of-life care. It's not very easy at all to practice this. As you said, there are several questions that come up, and day in, day out, we kind of get patients or their relatives to sign the DNR form. And although we haven't yet got to the culture of having an advanced care plan or advanced directives or living will, for that matter, because nobody wants to talk about death and dying, because people I think are still under the fear that if we talk about it, we are inviting that kind of thing. So that's a feeling that I get. But we'll open to the audience any questions that they have, and then then I have a couple of questions to ask Sir and Dhvani. I can see Pradibha ma'am's hand. Dr. Pereira.
When we talk of end-of-life care, two perspectives, definitely we will look. Youngsters also can reach end-of-life care. It's not that that doesn't happen to them, and end-of-life care is only for the elder. There is young, there is something to save them and to keep them back. So they fight for the life of the youngster. But when dealing with an elderly, especially oldest old, the family just makes the decision and say, no, you don't do this, you don't do this. Even if the elderly person is capable of saying something, whether he wants to live, it's very difficult. Where the elderly
Ma'am, your voice is breaking. Could you move to a place where it doesn't break, or could you put it in the chat, please?
See, if I may respond, I think, yes, that's quite true. It is, there should be no ageism in this decision. While many of the very elderly should have more opportunity to discuss death and dying. Now, the younger age groups are not exempt. Particularly, death due to fatal trauma can occur at any age. And so those people who are on very high risk jobs they can also envisage and discuss, their death and dying. In any case, anybody with a chronic ailment or anybody who has had multiple hospitalization and the disease trajectory is not going in a favorable way. These are the scenarios where discussions can begin. You see, advance will is only an instrument, okay, a legal document. But the process is a medical and a human one. Discussing the prospects, discussing death and dying and what our values and wishes and what decisions one must take concordant with these values and wishes towards the end. Now, these discussions must happen. Now, we can't be mired in a past where these technologies didn't exist and we had more natural deaths. Now, today we have the real present risk of landing up on in an ICU, on a ventilator, whether or not we have any prospects for survival. So therefore, such discussions are necessary. And I dare say, I have had such discussions with my patients for over 2 decades now. It is not difficult because it gets you the rapport with the families. They start to open up, and that eases their tensions. We have an opportunity to answer their queries. So I must say, most of the misgivings happen with the physician and the caregivers themselves. That I shouldn't be broaching this subject for fear of facing a reaction or fear of facing emotionality. I think we are here to support emotionality. I think Shobha, as a palliative care physician, will bear me out. We are here not just to look after the physiology, we are here to support the emotionality, the responses, and also to be a friend and to be a counselor. So these are the roles which are very important. We cannot shy away. What I would say is there is no reason why the practices which have gone on for so long about being shy of discussing death should carry on forever. Okay, there has been a lot of disruptive things that have happened in the society, and this should matter, should be a part of our disruption and change.
Right. Thank you, sir. Anyone else who wants to ask? I can see again Sinha sir's hand up. Yes, please go ahead, sir. Unmute yourself. Yes.
First of all, I'm not going to raise any question. First, if you don't mind, please give me 5 minutes to say something, to think over the issue. I have much respect for the panel members and all the participants and our judiciary systems. But do you think that we take oath on Gita during the procedure of the court? Anywhere in the Gita is it written? What the issue is today is going to be discussed. Is it written in the Gita, the holy book, which is recognized throughout the globe? The great epic Gita, even in the dying situation, Iksha Mrityu, in the Hindi word Iksha Mrityu, is given to Bhishma Pitama. He is on dying bed, many tears, but he doesn't want to die. He wants to see the whole scenario of the Mahabharata. After getting everything, after suffering every situation, after realization of all the sorrows of life, then he chooses, because it has been given by the God to him, to that whenever he wants to die, he will be die. But it doesn't accept the die. Is it ethical or not? It left upon you, panel members, all the audiences, all the judiciaries, because I take oath, we all take oath.
I want to respond to this. See, we talk about Ichha Mrityu. I think that's a poor translation of what we are talking about. Okay. Those were the days we could not interfere with natural death, right? This is a phenomenon of modern times. Okay. In the modern ethical practice, what we are thinking is that we won't interfere with the natural process of dying when every evidence points towards its inevitability. Okay, we are not interfering with the natural process at all. So all these artificial interventions in medicine, they are going against this principle of allowing natural death. And Ichha Mrityu can be interpreted as autonomy, patient autonomy, or individual autonomy. That is correct. That's what we are trying to allow. Firstly, inform the patient, have the patient well informed so that he can exercise this right of autonomy, and then honor it and enable it and combine it with your physician instincts for beneficence and non-maleficence. This is what we are talking about. It's not going against any of those religious or spiritual principles we have grown up with.
I think Sinha sir's audio is muted. I think you need to unmute yourself, sir.
Sorry, I'm unmuted. I have been speaking just now.
Yeah. You were muted, sir, so we couldn't hear what you were saying. So please say again. Dr. Sinha ji, बताइए.
या मैं वही कह रहा हूँ कि क्या ये प्रॉक्सी, मैं इसको ये मान लूं कि जैसे 2020 में मैंने देखा है, कोविड के समय मैंने अपने पापा को कोविड में खोया है. कोविड के कारण से मेरे पापा की डेथ हुई है. He was suffering from diabetic patient. He was a diabetic patient. He was suffering from so many diseases because मैं ये समझता हूँ कि डायबिटीज एक स्लो पॉइजन की तरह होता है, स्वीट स्लो पॉइजन जो धीरे धीरे सारे ऑर्गन्स को खत्म कर देता है. बट आई माई सेल्फ ट्राई टू कि मैं किसी भी तरीके से अपने पापा को बचा लूं. मैंने 15 दिन तक कोरोना वायरस के 15 दिन तक मैं डायरेक्ट एक्सपोजर में रहा. मैंने ट्राई किया, मैंने स्ट्रगल किया कि मैं लाइफ को उनका सेव करूं. तो क्या डॉक्टर्स, मेडिकल टीम्स हार गया है डेथ के सामने, डिजीज के सामने? डेथ के सामने तो मैं मानता हूँ डेथ इज ए नेचुरल प्रोसेस. अगर मुझे जन्म अगर हुआ है तो मेरी मृत्यु होना निश्चित है. लेकिन क्या मैं छोड़ दूं पेशेंट को मर्जी पर? हर कोई आदमी अगर चाहे कि मैं बहुत तकलीफ हो रही है, मुझे इंजेक्शन लेने से, ये ऑक्सीजन लेने से, अब मुझे डॉक्टर ऐसा कुछ दे दे सुविधा कि मुझे डेथ आराम से हो जाए, क्या ये इंडियन कल्चर एंड ट्रेडिशन एंड एज
आपको एक चीज से मैं अवगत करता हूं.
सिस्टम.
सिन्हा साहब, मुझे थोड़ा सा अवकाश दीजिए, मैं आपको अवगत करता हूँ. हम तो रोजाना डेथ से ही तो स्ट्रगल कर रहे हैं, पर डेथ जब आता है ये किसी की डिफीट थोड़ी ना है. ऊपर वाला ही ने हमें भेजा है, ऊपर वाला ले जाता है. Neither of which is a defeat. The issue is when there is a chance for the medically and scientifically and logically there is a chance. I mean, that is what I'm doing day in, day out as an intensivist. Always, first thing is instinct is to rescue, save. But it has gone too far. When you start to interfere with the dying process, which is inevitable because you can't think any different, it has become a reflexive action for you, not a reflective action of taking the whole situation of the patient and have a comprehensive understanding of where we are heading, what we are doing, what is to be expected. All this is a part of medical care. So nobody has been able to conquer death, as I've said. All the sciences, technology, we have been able to postpone, yes. We have been able to increase lifespan, yes. We have been able to prevent a lot of avoidable deaths. And we have been able to save from many diseases which were hitherto we could not reach. Okay, there were malignancies which we could not reach some 30, 40 years ago. Now, let us talk about terminal illness. Okay, so all that has been defined. Okay? And the courts have understood this. That's how they've allowed a process in the context of terminal illness. Let's not leave the context. Okay, nobody could prevent the end of Bhishma, and Krishna himself did not interfere when the poisoned arrow hit his foot. So the issue is every avatar has passed on after the purpose was over. So what I'm trying to tell you is, if you take the human condition as a whole and understand it from that perspective, not as a physiological aberration which we have to correct all the time, then you understand what we are talking about. And that's how we have to view the patient. Patient is a person, right? Sorry, I shouldn't be using the word patient. I apologize. The person in whom the disease has happened and he has put trust in me and come. I must look at the person as a soul, then as a body, and then whatever I can do to the body, I'll do. But if that has come to an end, then I will look after his humanistic needs at that point in time.
Thank you very much, sir. I think Sinaji, I think he has put things in perspective, and we will go forward to the next person. Does anyone else want to have ask a question to Dhvani and Manisa?
Dr. Mehta, I know there's a few questions you've been answering in the chat. I don't know if you want to elaborate on any of those.
No, I think they were all procedural questions, really. So hopefully the answers there should have cleared it up. But of course, if there's anyone who wants to ask more about them, they're welcome to. But yeah, I don't think there's anything to elaborate on.
Thank you, Dhvani. So I can see Mark's hand up. So Dr. Mark Candro is a palliative care physician from Louisiana, USA. Mark, please go ahead.
Yeah, hey, thank you. That was a fascinating presentation. Having dealt with advanced directives and all of these things for so many years, there's so many ins and outs to it that are interesting to consider. I have to think based on your most recent comments, Dr. Mani, that, since 19, opportunity of dying in every single decade in our life when we were born, and now simple ear infections that would have taken the life of a child can easily be treated, and on into advanced age, advanced chronic illness, often terminal illness. And you're exactly right. How do we take care of people appropriately with all of the medical interventions that we have, but also respect that human being and the natural life that is drawing to a close? It's very interesting. And then when you combine that with advanced directives and trying to allow people the opportunity to have a voice in how they should be cared for at the end of their life, it's all the more interesting. And then when you combine that with that conspiracy of silence that often happens between providers and patients, when there is not really an opportunity to talk about what's most important because the opportunity is never offered. It really speaks to the culture of the medical community that we exist within, and that it takes years to address. One interesting thing I just wanted to comment on as we talk about advanced directives is, even in the United States, there's been a lot of very recent scholarship about whether it's helpful or not, sort of thinking about the idea that it's all very abstract, how you think about illness and the end of your life and what you really want. And then when that time comes, that may really change, and that the most important piece of advanced care planning is really appointing somebody who knows you very well and knows what kinds of treatments you would want and what kinds you would potentially want to be protected from. And so, kind of that idea, we want everyone to have all the care that they desire, but also nothing that they don't want. So anyway, thank you for that very interesting presentation. I loved it.
Thank you for your lovely comments.
And
you said something about silence. That of course silence is also healing too. in our conversations. So very, very important, why in the practice, if you don't practice end-of-life care, you're not really practicing. Because that is the medium, that trains you to communicate, that trains you to listen, and to keep silence when it is inappropriate to speak up. And, I think these principles I would have never got from my medical training. It's the touching the palliative care energy, right? When you talk to a patient, touch the patient, think about, in a wholesome fashion, how you take decisions and involve them, honor their thoughts, their
Oh,
feelings,
absolutely.
their experience. Yeah.
Right. When I was a resident in training, I would have a list of my patients, and we would say at the beginning of our shift, no one will die on my watch, as if every death was a failure. Well, what if it was that person's time to die,
Exactly.
Yeah, you can create so much suffering.
Absolutely.
So that is the bottom line. It's the suffering. It is not a pancreatitis, right? It is all the suffering at 4 different levels, which Dame Cicely Saunders talked about. The four dimensions of pain. Now, see, if we are only confined to the physical symptom, then we are missing out a great deal of personal growth as a physician as well, as a caregiver.
Oh, absolutely. And look, we're all human beings. We all want the same things. We want to live long, healthy lives. We want to be loved by our families. We want to love our families and those people who are important to us. And when we come to the end of our life, we don't want to suffer, and we're all the same in that respect. But, often patients and their families are not provided with that guidance that's really required to understand where they are in the trajectory of their life, so they're not that 20-year-old full of vitality or that 40-year-old full of vitality, that they're that 88-year-old who is in the final phase of life. And how do you take the very best care of that person? Often it is very different, obviously, from somebody who's 20 years old, who you would immediately be putting on a ventilator and doing CPR on. But, the person with chronic medical illness, we know medically that is not the right thing. So why should the law force us to do things that we know medically and humanistically are inappropriate?
Absolutely.
So, yeah.
Absolutely.
Thank you.
Thank you very much.
Right. Thank you so much, Mark, for that discussion. Anyone else from the audience who wants to ask?
I think I would just add to it, it was such a humbling experience to really listen to you, and, Dr. Raj and Dhvani and Mark. Thank you for that meaningful conversation. And also for Dr. Sinha, for asking a very intriguing question, which is something that needs to be discussed at every facet of life and being there. But I think I just wanted to add one more thing to Mark's comment that you made. It's just not our suffering, right? We are also looking at the people who are carrying us and what they have to go through. And does it really make sense putting them through that? So I think that is another addition that we think as a person who's going through this situation, want to just have that autonomy to say, hey, you know what, let me make that thing, right? Let me make the decision, it's time. I've had a wholesome life. I've done this, and so it's that kind of reasoning and thought process. I think where there's a lot of education that needs to happen, but it was a phenomenal discussion. So I just wanted to thank you for that.
There was one question here which I'll answer. What is your view about these laws that are coming more and more countries about right of euthanasia? Now, yes, it's a very important question. Now, euthanasia, what we mean by it is active euthanasia. Now, it's an obsolete word. It has been replaced by medical assistance in death. Now, all that we have been talking about, withdrawal, withholding, DNAR, are not medical assistance in death. It is just an omission not to do something, right? As per the judicial interpretation, omission, isn't it, Dhvani? It's not actually actively intending to or acting upon accelerating the death through through a lethal injection or through a lethal prescription. And that is allowed in about, I think, 7 or 8 countries in the world and 10 states of the USA. So you see, that's the other end of the spectrum. If we have a spectrum of treatment limiting decisions, from the simplest to the most complex, is DNAR, withholding, withdrawal, and ultimately MAID, a medical assistance in death. Medical assistance in death is justified on the basis of autonomy. Now, you don't dilute the autonomy, right? If you have autonomy, you have it. Why should you put so many conditions? Because it's something very personal. So that is the angle some citizens of some nations have taken, and they have voted for such a provision. I think we are very far away from there in our country, because we have to first properly be grounded in the less challenging decisions, right? DNAR with withholding withdrawal. In some countries like Canada, they even donate organs by choosing to have MAID. I mean, so many different ways it explodes our current understanding of ethics. Okay, so all that exists, we know it exists, but we have to go a little slowly here with ourselves, because I don't think we can jump steps. We got to get grounded in our understanding of death and dying, and that technology can go very wrong, right? As we discussed in Reema ji's presentation, AI, what are the limitations? Somebody asked. So important. Anything new, you have to have some model, ethical model, where you envisage what can go wrong and have checks and balances. So today in our country, we are going wrong on the overuse of technology. We are going wrong in getting excessive treatment. We are spending our resources uselessly and in fact harmfully. So let us get there first and bring in this humanizing process, which is also sensible and scientific process. They are not different, they are not opposite. The more scientifically evidence-based you are, the more humanistic you will be, and more appropriate you will be in your treatment decisions. Are we not misusing antibiotics? For instance, you look at appropriateness, that is your antibiotic stewardship, natural. And you won't get into this multi-drug resistant situation. So this is what is lacking in the country. And Dhvani and I, are partners in this campaign for a very, very, and all of you, of course, we are all, I think, kindred spirits who must never let up on this campaign, because it touches so many areas of medicine that we can no longer afford to ignore it. Yeah.
So thank you very much, sir. I think to put things in perspective, I think on the other side, like when sometimes people refer patients to us, they expect us to kind of start the patients on a cocktail, morphine, haloperidol, or midazolam. And when we don't do it, some of the other consultants would come and ask us, why are you not doing it? And then we would explain to them, well, we need to look at like what's happening with the patient first. And we don't, just to, answer Synergy's question, it's like, as Mani sir rightly said, for us, it's about, getting quality life for as long as possible. So if there's any correctable thing, we will be doing it. For example, the other day, we had a patient with a base of tongue cancer and completely blocked. The whole face is swollen. Thankfully, he had a tracheostomy in place, and it's a local thing, and he was going to die of starvation. So we put him on a very high dose of DEXA. His swelling came down. We could do an endoscopy and put in the feeding tube. And he's at home, and his wife is looking after him. So there are patients who the relatives want the patients to be at home, and they're willing to look after them. And
Shobha, you would recall a paper by Temel, which was published in the New England Journal maybe 4 or 5 years ago. It was about treating non-small cell cancer.
Yes, sir.
Now, in a cohort of patients, when they introduced palliative care right in the beginning,
exactly,
not later on, they there was more foregoing of life support in those patients and longer lifespan.
Exactly.
Up to 3 or 4 months. Longer, they live longer.
So that
not
was
having these unnecessary interventions and also having a qualitatively superior, which was measured as well.
Yeah.
In the depression and anxiety score and the functionality scores, all of them are better. So I want to say that palliative care is hardly throwing in the towel or accepting defeat. It's becoming more sensible, more intelligent in the caring.
Absolutely. So totally agree with you. And I have, like you said, rightly said, I have this problem with this passive euthanasia. So Dhvani and team, can we take that off from a legal language? Is it possible?
It should be taken out from the legal language. In fact, as Dr. Mani's, I mean, unfortunately, the court continues to refer to withholding and withdrawal as passive euthanasia, and most of the media tends to report it as that, like that as well. But if you look at the document that Dr. Mani referred to, the ICMR has issued this document on definitions of terms related to end-of-life care, and there's a very clear explanation of why this term should be avoided and what exactly withholding and withdrawal means. And I think the more medical associations and professional medical bodies issue guidelines that don't, that refer to this as foregoing life support, withholding, withdrawal, and don't use passive euthanasia, I think the more that will fall out of currency, and the more medically accepted term will be used later. And of course, in the bill that we have drafted together, we have not referred to that phrase at all. So hopefully, yeah,
it's a monkey on the back, which we are enduring for the moment, but we will shake it off as soon as possible.
Yes, sir. So the one last point that I wanted to mention was between withholding and withdrawing. We always feel withholding is comfortable. And we, of course, when we talk to patients, we would talk about futility and somebody who's going to be alone in the ICU with all sorts of tubes around and the family waiting outside, not knowing what's happening with the patient. So terminally ill patient, like you said, with a 4th stage cancer, or sadly, during the past few years, COVID, people who had comorbidities like diabetes or you name it, other comorbidities, they succumbed to COVID before we could save them. So, and I think like you would have treated a lot of patients, and you would have put them on ventilatory support, or put them on supine position, gave them oxygen, gave them whatnot. But a point came when we could not save them,
that happens in 30 to 40% of cases.
Absolutely.
By world statistics. So what I'm saying is not infrequent.
Yes, sir.
What happens is majority of doctors, we publish and declare our successes and hide even from ourselves, the so-called defeats, but that's not science.
Absolutely, sir.
We know that in severe ARDS, mortality is 40 or 50%, even today, even after 3 decades of all technological evolution. I must say a little bit about withdrawal and withholding, which you brought up, Shobha.
Yes, sir.
See, you might have heard of Beauchamp and Childress.
Childress, yes.
The seminal book on
ethics,
on the principles of bioethics, which is the Bible for us in bioethics. Now, they have clearly said at length, the whole chapter is written, that the premise for both withdrawal and withholding being the same, there is no ethical difference between the two. Since after withdrawal, death seems to be more proximate than after withholding, you might attribute the act of withdrawal as what is as being causal of death, which is not correct. The cause of death is already determined in your prognostication and your diagnosis. This is you are omitting to interfere. That's all.
And there's no
legal. It may be a more difficult. Yeah, it may be a more difficult decision from the perception point of view. Okay, family may perceive it, so that is why they have to be prepared better. You have to open up a conversation more in depth and take questions and also project what could happen and explain much better for withdrawal than for withholding. And likewise, your documentation has to be also more elaborate. Otherwise, ethically, there's no difference. I don't differentiate between the two for the simple reason, if you had only withholding and no withdrawal, then you won't attempt or give a trial of intensive care for those where you're not sure.
Exactly.
See, medicine is full of being unsure. And one who is cocksure cannot practice good medicine, right? One has to feel one's way, right? And must admit to oneself that I'm not sure. Then you can provide temporarily a support which you want to see whether it works or not. And that opportunity you won't have if you could withhold but not withdraw. Because supposing the trial fails, and have you imprisoned the patient on the ventilator? So these are illogical. So as a doctor, one should have clarity of thought that I'm prescribing either of them for this reason, that it's not going to work for the patient. And I made sure that I'm right by following up over a period of time. And also I make sure by also scientific methodology, we have for every system, every sort of disease, you have scoring aids, right? And also your own experience and also your discussion with your colleagues. So you have to use subjective and objective methods of prognostication. This is what our guidelines say, our guidelines to the intensive care specialist.
So withdrawing,
either, as in the court's guidelines apply to both withholding and withdrawing, and it's the same procedure.
so you can withdraw without getting into any legal complications.
Absolutely.
Same process.
To confirm that.
Yeah.
And incidentally, I've withdrawn scores, maybe hundreds. Okay, I have not had a whiff of any court cases on these issues. Let me also tell you that.
One last
question.
question.
I'm lucky by maybe, but you see, the process is important. It's not the outcome.
Yes, sir.
If you take the process as it ought to be, as a physician and as somebody aware of the legal requirements, then you don't have to worry about it. Everybody has a right to sue. I have the right to sue as well and to protect myself. So what? We have to keep it to the process, and then we are not going to practice defensively.
Right. One last question by Mark. He has raised his hand.
And it's really just a comment
Okay.
that, although yes, ethically there is no difference between withdrawing and withholding, they feel different. And, particularly in the United States, where we really have swung from paternalism to extreme autonomy, and all of these decisions are placed in the hands of families, it makes it particularly difficult when the entire treating team feels that withdrawal is absolutely the correct medical thing to happen, but the families then are given this decision to make about withdrawing, and they feel responsible for the death of their loved one when they make that decision. So yes, it's a fascinating subject that, yes, ethically there's no difference, but it certainly does feel differently for families when they're in that position. That's why not doing it is certainly better than having to do something and then back out of it. Yeah.
I'm so glad that across different settings, Mark and you and I practice in different settings, the basic principles are so clear and works on both sides. Yeah.
So in fact, when people sign on the DNR, that the kith and the kin, they feel as if they are signing a death warrant. So they would say, okay, I need to wait for my brother to come in. I need, of course, they can take a consensus and do it. Sometimes it so happens that some different family members will have different opinions. And then, of course, we call a family conference, we make them sit together. Sometimes they have not spoken for years together, the siblings, and they come together when their father or mother dies. So we come across all sorts of situations, all sorts of humanitarian crises, I would say. And then we, go on and practice.
Absolutely. It's an opportunity to talk. If they have such ideas, it is not that they are impervious or they are being foolish. They are just being partially informed. So we have to take that opportunity and take that view. And I think without patience, there is no great conversation.
Absolutely. So. Right. So there's one question that I can see from the chat. Will the certificate of participation be provided for this webinar? I'll leave it till the C20 leads for them to answer. It's Dr. Pankaj Kumar who has written this. So if no one else has any burning questions, I think we'll come to an end for the a fruitful discussion for the past 2 hours, I must say.
There is Miss Bakshi who is raising her hand.
Oh, is it? Sorry. So Manorma, please go ahead. Unmute yourself, please.
I can't unmute myself.
No, you can. Yeah, we can hear you. Yeah.
Yeah. Actually, my question is that, long time back, I'm talking about in early 90s when HIV/AIDS was there, and a lot of awareness campaigns happened so that people knew that how they Can you hear me?
Yeah, right. Now it's okay.
Yeah. What I'm saying in early 90s, when HIV/AIDS was there and it was at highest level, like a lot of, awareness and, kind of campaigns happen so that people were aware, like, so that they won't stigmatize or they won't discriminate against these people. Don't you see that this, what we call about, the law? I mean, people need to be educated about it. They need to have, I think the ministry should come out with some kind of, awareness campaign so that people are aware about palliative care. Palliative care as of now is not really taken off very well. And I think that what are the measures that we need to do so that people are aware, like what we are talking about, end of, life care and those kind of things. I think that it was only during Anjana's case when people used to talk about these kind of things, and then how law followed. But this is the right time and opportune time when we should talk about palliative care as well as right to end of life. So these things, and if we can have some kind of,
I think that's wonderful. Right to end of life care. That's music to my ears, and that's a right we all must have, and we are talking about every citizen's right.
So maybe we can put that in our policy, which we are working on, Manorama.
Exactly.
We have a working group, and in fact, a legal domain, Mani sir is there in that, and we're together working on it. And in that, we can include, sir, the right to end of life care, right to life, and right to pain relief, right to end of life care. So
Lovely. I think it's Dhvani's task to ensure us this right.
Right. So I think with that, I think we will formally close this discussion. I think it can go on forever. I think people who have remained back are the people who are really, really interested. And I'm told by our tech support that this video recording will be viewed by many other people who are interested. So not to get disheartened by the number of people who attended is what I've been told. So I said, that's absolutely fine. I think we had a really good, wonderful discussion. I can't thank you enough, Reema, for getting up so early. From all the way from San Diego, you've attended. There's been very patient sitting through, and
Wow, it's been a great pleasure talking to you and
Thank you, sir.
interacting and listening to you about AI.
Yeah,
wonderful.
thank you.
And Shobha, you too.
Thank you, sir.
Wonderful interacting
Let's
with you.
thank you, sir, first. Thank you. So, so Reema, you're a star as always. So thank you so very much. Okay. And Dhvani, every time I have messaged you, immediately you've responded. And as well as Mani sir, in spite of his busy schedule and in spite of being so senior, he's never dropped that line. Every time you message him, you get replies back immediately. Yes, let's do this, let's do that, that sort of thing. So it's such a pleasure to have worked with you, sir. And we haven't completed our legal domain. I have had a look at your document. And I'll get back to you on that, sir. I'll tell you on that. And thank you, Mani, so much for whatever you're doing for our country and for all the patients in this country who, deserve dignity in death. Thank you so much. And this webinar wouldn't end without thanking all the participants who have, come up with questions. Sinaji, thank you so much. Manorama ji, thank you so much. And Mark, of course, thank you so much. He's part of Amrita family, I would say. Thank you so much for pitching in with the right at the right time with the kind of responses that you've had. And a big thank you to the tech support, Sudha, Navneet, and Krishna Priya, and our Dr. Priya Nair, who's a gastroenterologist with our institution, who is the main lead, the two co-leads for C20. Thank you so much. She initiated the webinar today. And last but not the least, our ground man, Mr. Srijit. Thank you so much. So thank you so much. In Amma's name, Jai Hind. Bye.
It goes without saying, Shobha, fantastic host. Very well done, very well done, Vivi. And thank you from all of us for doing that. And again, thank you in behalf of the entire panel to the tech support and for the active participation. It was an immense pleasure to participate. Thank you.
Thank you.